Good morning, good afternoon to everyone. My name is Marco Masetti. I'm a transplant heart failure and cardiologist from Bologna, and Laura Borghese, everybody, you know her, of course. So in the next 20-25 minutes, we will have a brief overview, as Dominic and many others asked us, about the clinical management of chronic heart failure. So first of all, what's heart failure? You all are aware of this. Heart failure is a clinical syndrome where the heart is not able to generate a cardiac output that is adequate for the metabolic request of the peripheral organs and tissues, or if it can do it, it can do it increased filling pressures. Its prevalence is quite high and is probably underestimated. It's 3% in the overall population, and increases according to increasing age groups. And it's the leading cause of hospitalization in people older than 65 years. Of course, it's not a yes or no, black or white phenomenon. It's a continuum. So as you can see here on the left side panel, there are different stages of heart failure. And classically, without going into the detail, the symptomatic heart failure can be classified according to the ability or the capability that has the patient to perform a physical activity. So it's a kind of subjective measure, of course, and it's classified in 4 classes that are called NIH classes. Class 1 is the mildest, class 4 is the most critical one. In class 2, patient has some limitations in the everyday in the moderate physical activity. Class 3, the patient has limitation in the everyday physical activity. Class 4, patient is symptomatic at rest. So when we talk about heart failure, we talk about all these different classes. The survival of heart failure, of course, is different according to the different stages. As you can imagine, is worse in the more advanced NIH class. And if we compare the survival of heart failure to the survival, the predicted survival of the most common cancers, as you can see here, patients with heart failure have a worse outcome, for instance, as compared to prostate cancer, and have an outcome that is very similar to lung cancer. So it's a very impacting disease on the healthcare system. How is the clinical course? So traditionally, at the beginning, there is a dramatic onset in most of cases where there is a dramatic drop in the quality of life, and it's the moment where the patient, where we make the diagnosis. The symptoms of heart failure, as I said, are limited exertion capacity for dyspnea and intense asthenia, of course. These are the most common clinical aspects. After the first phase where the diagnosis is made, the medical therapy is started, and afterwards some kind of stability is reached, and it can last for several decades. But afterwards, during the subsequent follow-up, the patient can have many decompensations, and after any decompensation, the clinical scenario is again better than before the decompensation, but even worse than it was before. So at the end, after several months or several years, depends of course on the clinical picture, you can achieve a sort of advanced heart failure where the clinical therapy is very challenging and where there is pump failure, so that the patient can be candidated to palliative care if he's very old with several amount of comorbidities, or to a substitutive therapy that is basically heart transplantation or mechanical circulatory support. What are the causes? Of course, the main cause is the pump. So a bad performance of the heart, but also the periphery is involved. What about the pump? When the pump fails, we have to, of course, think to the pump contraction. So in most of cases, we talk about the systolic heart failure. That is a situation where we have a reduced pump contraction. Ejection fraction is the main parameters that we can evaluate, and we traditionally evaluate it with echocardiography. So we talk about a reduced ejection fraction if this value is below 40%, or only mildly reduced if the value is somewhere between 40 and 50%. But there are also conditions that are called diastolic heart failure, where the heart force, the heart systolic efficiency is completely normal, so the ejection fraction is completely normal, and the problem is within the relaxation properties of the heart. So in this situation that is called heart failure with preserved ejection fraction, it is quite common. We can have a normal heart if we look only at ejection fraction. I'm sorry for these pictures because they don't work. So briefly, we can have different heart diseases that can lead to heart failure. I will not go through them, of course, for the scope of this meeting. The most frequent are ischemic cardiomyopathies and so related to coronary artery disease, and cardiomyopathies often on a genetic basis with different phenotypes, but also valve disease, pulmonary embolism, pericardial disease, and more rarely cardiac tumors. In other situations, the periphery can be the cause, or at least a situation that can worsen the clinical scenario. There are conditions in where the heart is only mildly impaired, the heart function, but if the demand of the metabolic demand of the periphery is severely increased, heart failure can still occur. And these conditions are sepsis, anemia, hyperthyroidism, arterial hypertension, pregnancies, and many others. How to diagnose heart failure? Without going into the details, these are the main techniques that every day we perform. Of course, electrocardiography, it can inform us about rhythm disturbances, blocks, arrhythmias, and whatever. Echocardiography, that first of all has the very important function of distinguishing the two phenotypes. So systolic heart failure with a reduced ejection fraction, or diastolic heart failure with normal ejection fraction. And as a second reason, echocardiography can inform us about the type of heart disease that is beyond the diagnosis of heart failure. Of course, coronary angiography, if you wanted to rule out the coronary artery disease, and cardiac MRI, magnetic resonance, is also very useful, especially in some particular rare hypertrophic disease or infiltrative disease. And endomyocardial biopsy, it's quite uncommon, but it can be performed in some specialized centers, like most of the centers that are participating to this project, to clarify definitely a very rare cause of cardiomyopathies, arrhythmogenic cardiomyopathy, or rare metabolic-related cardiomyopathies. Stress echo, treadmill test, these are provocative tests that looks for ischemia, underlying ischemia, so they are directed if we have a suspicion of coronary artery disease. PET, and finally, right heart catheterization. That is an exam, an invasive exam that can give us useful information about hemodynamics and can help us in guided medical therapy. So which are the phenotypes? Very simply, low cardiac output if the heart function is poor, or increased filling pressures if the problem is within the relaxation property of the heart. Of course, we can have both the cases that can coexist. So most commonly in patients with systolic heart failure, we have a severely reduced cardiac output and increased filling pressures that can be even normal. Filling pressures within the heart, of course, that can be normal if the patient is compensated with the medical therapy. In diastolic heart failure, more classically, the cardiac output is normal or only slightly reduced, and filling pressure are extremely high. These different phenotypes can combine themselves in different scenarios. So we can have the scenario of that is the best of a patient that is dry, so without congestion, so with normal filling pressures and with an adequate cardiac output, so-called dry and warm. Or on the opposite of the clinical picture, we can have a patient who is wet and cold, so with congestion, with increased filling pressure, and with reduced cardiac output. And this is the patient with the worst outcome. The clinical picture is different. The patient with congestion has orthopnea, that means difficulty to breathe without maintaining an upfront position. jugular venous distension, rails, ascites. So we can basically find fluids in several districts of the body. Or compromised perfusion. In these cases, we can find narrow proportion pulse pressures or hypotension, sometimes if the hypotension is particularly critical with impaired mental status. So how we can make the diagnosis by the physical exam? If we want to look for congestion, if the problem is in the right heart, so in the right side of the heart, in the right ventricle, for instance, we can have a picture like this into the right. So the patient can have the water within the legs, within the liver, within the gut. So the patient has a distension of jugular vein that is increased because of increased central venous pressure, and the big size, so to speak, of the liver and of the spleen, and of course leg edema. On the other hand, if the congestion is related to left side heart failure, the liquids are within the lungs, so the patient can have dyspnea and orthopnea. So these are two different scenarios in clinical picture. How is the low cardiac output phenotype? We can have basically a mild hypotension with a mean blood pressure below 70 millimeters of mercury, tachycardia, but we can have also cachexia if the low cardiac output is long-standing. So for several years, the heart cannot perfuse adequately or the organs, or cardiogenic shock, that is the most dramatic clinical scenario where the patient is an acidosis, is a very high lactate level, reduced urine output, and it requires intensive care and inotropes. So what is the therapy of heart failure? It seems very simple. We can have congestion, we just have to take fluids off with diuretics, with filtration, dialysis. We can have low cardiac output, we just have to increase contractility, maybe with inotropes. So these are the basics of heart failure if we think of heart failure as a mechanicistic process with a pump or periphery different phenotypes. However, if we look at the current guidelines of the European Society of Cardiology for heart failure, we can see very clear that diuretics can reduce hospitalizations, but probably they cannot reduce mortality. And the inotropes, the effect of inotropes on mortality is absolutely uncertain. Why that? And why are these other drugs mentioned? Because heart failure is not only a mechanicistic process, but it's a, so to speak, hormonal process. What happens if we, in conditions of heart failure? When the cardiac output is reduced, there is an overall vasoconstriction and an increased heart rate. This leads to compensatory mechanisms to the production by the kidney of renin that stimulates angiotensin 1 and angiotensin 2 production that leads to vasoconstriction at the level of arteriole of the kidney, of the brain, and of all other organs. And this is a sort of compensatory mechanism to preserve the flow, but at the end is a negative mechanism. So without making too long a complicated story, just to tell you that during heart failure, the patient has increased level of angiotensin 2, of natriuretic peptides, and this is and of aldosterone. This is crucial, is very, very important, because it has been seen in the last years that when filling pressures are increased, the atria are stretched and they produce natriuretic peptide, like for instance, brain natriuretic peptide. And this can lead to a loss of water and of sodium within the urine to try to balance the poor perfusion and the increased filling pressures. So the actuarial medical therapy for heart failure are acting on these different molecules. In particular, I will not go into detail through them, of course, for the scope of this meeting, but ARNI, these are molecules that inhibits the angiotensin 2 and favorite the product that is a negative hormone, so to speak, for the heart, and stimulates the production of BNP, so they have a positive effect. MRA, these are directed against aldosterone. And the new SGLT2 inhibitors are directed within the tubule of the kidney to favor natriuresis. So the actuarial more recommended therapy for heart failure basically acts within these hormonal substances. And these are the so-called fantastic four. So we think, when we think actually to the therapy of heart failure, we think to these four drugs: neprilysin inhibitors, antagonists of aldosterone, SGLT2 inhibitors, and beta blockers that reduce the work of the heart. So what are we talking about? If you look at the story of heart failure treatment, these new drugs, particularly the last two, have been faced in the clinical scenario in the last 10 years. And our centers have just designed an Horizon project about focusing specifically on a therapy that is used since 70 years. So why this can be a sort of paradox? Why did we make this choose? And not on the other drug? Because this newer drug for heart failure, so the actuarial therapy for heart failure, is absolutely crucial and has a strong impact on mortality even after a few weeks that you started. If you look to these figures that are derived from the main trials of these drugs, you can clearly see that the effect, for instance, of this drug, empagliflozin, is evident after just a couple of weeks that it has been started, and more or less the same for sacubitril/valsartan, that belongs to the class of ARNI. So we have to start this drug very, very soon, especially in the patient that has been recently hospitalized for heart failure. However, if we look to the reality is very difficult, because up to now, only a few patients are treated with these four pillars of heart failure therapy. And in particular, if we look to what it happens after hospitalizations for heart failure, you can see that, for instance, there are some drugs that are interrupted very often. For instance, the MRA and ARNI are interrupted in 30% of cases. And there is also a consistent proportion of patients that could have the indications to use these drugs but are not treated. So as you can see here, for instance, it happens in about 30% of times for these newer drugs. And this is true because of this is related to the clinical pictures of heart failure, because as we said at the beginning, after the first phases, you can have several moments of worsening. And every time the patient is hospitalized, a new drug can be withdrawn, and sometimes it is not restarted anymore. I'm not going to the details, but as you can see here, the more advanced heart failure stages the patient reaches, the more his blood pressure is lower, or her blood pressure is lower, the more his renal function is worsened, and progressively these drugs are withdrawn. So we are basically talking about advanced heart failure, that is this clinical scenario: severely reduced ejection fraction, frequent hospitalizations for heart failure in recent times, severely impaired functional capacity, frequent arrhythmias, high dose of diuretics. These definitions are not fitting completely the inclusion criteria of BIOTOOL-CHF, as you can see here, but if you look at the inclusion criteria of our project, some of these characteristics are included, perhaps in a more moderate stages, because we wanted to capture this everyday clinical scenario. So as we have just said, in the most advanced stages of heart failure, the use of guideline-directed medical therapy is very, very low. This why? Because one problem is related to the use of this 70-year-old drug that is diuretic. Diuretic is like the Linus, I don't know what's the word in English, but you understood me. It's like the Linus cover for the heart failure cardiologist. We are very afraid to keep it off, but it has important side effects like worsening of renal function. And this can lead to a lower use of the other drug that I just mentioned, that have a tremendous, more powerful impact on prognosis and hospitalizations as compared to diuretics. Diuretics can also lead to diuretic resistance, to hypopotasemia that can be deleterious because it can acts as a trigger for ventricular arrhythmias, and it can lead also to ototoxicity. But we are still very afraid to avoid diuretics. And also the other drugs, of course, have several adverse effects that are depicted here. But the interesting is that if you look here at the different side effects of the other heart failure drugs, we can find in all drugs renal failure and also hypotension. So again, one obstacle to guideline-directed medical therapy in advanced heart failure, apart that advanced heart failure is poorly represented in clinical trials, is that all goes around the assessment of congestion, cardiac output, and renal function, and it's very difficult to do in the clinical practice. And of course, we as doctors have to say that we have also clinical inertia sometimes. So, as said, all goes around to evaluation of congestion, perfusion, and to kidney function. The problem is that creatinine can be high due to poor perfusion, so if we have a low cardiac output, but also if the patient has a very high congestion, so if we are giving him to less diuretic, or if the patient is too much dehydrated, so if we have given him too many diuretics. So we cannot use the creatinine value as a marker of our clinical action. Why did this problem about congestion rise up only now and not in the last 50 years? Well, it did rise up also in the last 50 years, but the problem is that the newer drugs that we have available now have natriuretic and aquaretic properties. That is that these newer drugs have somehow diuretic properties. So they have simplified they have improved the management of heart failure patients, but they have a little bit complicated our life as a clinicians. And how do we evaluate congestion? This is very important because clinical exam can underestimate congestion in 30% of cases. Congestion overestimation can lead to excess in diuretics dose and thus to worsen renal function. Congestion underestimation, on the other hand, especially visceral, can lead to worse renal function. And this is the case of cardiorenal syndrome. Why that? Because if you think at heart with increased filling pressure, especially in the right part of the heart, this increased amount of liquids is, transmitted in the vena cava and vena porta system, so particularly in the liver, in the gut, and the kidneys. So if the heart is very filled, the patient is very congested, there is also renal failure and the creatinine is very low. So as said, creatinine can be high due to low perfusion or also to too many diuretics or too few diuretics. So it's very difficult. But in 2024, how do we evaluate congestion into the reality? We just make the physical examination, as said at the beginning. We evaluate jugular veins, the symptoms, sometimes the biomarker, and we perform ultrasound to see the diameter of vena cava. The problem is that these parameters are very insensitive, and that the other problem is that these parameters evaluate only intravascular congestion, so the amount of fluids that is within the vessels. But we know that clinical congestion is delayed as compared to hemodynamic congestion. Hemodynamic congestion appears before clinical congestion is onset and disappears after clinical congestion is evident. So another way to measure intravascular congestion is right heart catheterization. That is an invasive technique where we directly measure the pressures within the heart, within the right atrium, within the left atrium, that is within the capillary circulation, it is a surrogate of the left atrium, it is wedge pressure, and we measure the cardiac output. So right heart cath is the most precise technique that we have to measure intravascular congestion. The problem is that an invasive procedure and is not available in all hospitals because it requires a cath lab. And even the more advanced technique of continuous monitoring of hemodynamics, like CardioMEMS, that is a sensor that can be implanted within the pulmonary circulations, are very expensive and very invasive. But the problem is that all these measures assess intravascular congestion, but the liquids can be also within the interstitium, within cells, so not directly into the vessels. And also in this case, this is the the water that goes into the interstitium is the water that goes in, the water goes there after that is within the vessels, and it goes away from there after that it comes back away from the vessels. So again, this is a very difficult measure to do. How do we measure interstitial congestions? Ideally by CT scan of the lungs, of the liver ultrasound, and impedensometry. How can we measure intravascular congestion, as said, with Reiter cuff? How can we measure perfusion, that is the other actor of heart failure? By placing an arterial line. So by placing invasively a catheter within a peripheral artery and measuring the arterial pressure. So this is the ideal, the most perfect, the book of the dreams to measure congestions and perfusion. The problem is, as you can see here, that all these exams must be made within the hospital. They are quite expensive and require specialized centers. But up to now, we still use physical exam, even to look for interstitium. We just look to the legs and to the lungs by using ultrasound. And this is a very imprecise method. Recently, sensors and bioimpedantiometry have been suggested to evaluate also the total body water, and thus having an estimate of interstitial liquids, but we are still in a work in progress. The problem, of course, is also after discharge. It's difficult to evaluate congestion also after discharge, and it's difficult also to evaluate diuretic response. This is how the guidelines suggest us to evaluate the response to diuretics. Just a numeric approach, just to see how much urine went out of the patients, but this is not a measure, again, of congestion. So we miss, after 70 years of use, a measure of congestions. What about biomarkers that are the key point of our project? As you know, biomarkers, well, we can say that there are already traditional biomarkers that are used in the clinics that are bilirubin, creatinine, and NT-proBNP, so markers that are informative, respectively, of the function of the liver for bilirubin and of the kidney for creatinine. But as I said before, these have several limitations. Creatinine is dependent on the muscle mass, of the skeletal muscle mass, so it can be falsely normal in patients who have a very poorly represented mass, that are cachectic, and bilirubin and transaminase can be increased also in other liver disease. So NT-proBNP is the most used agent, and this is a kind of biomarker that is released by the atria, as said before, when in cases of increased pressures within the atria. And it has shown a clear prognostic effect, so that now it is used in the clinical practice, but up to now, still the guidelines of the European Society of Cardiology do not recommend to use NT-proBNP to stratify prognosis and to guide therapy. But this is what we do in the clinical practice. What are the other biomarkers that are available now? Are these, and as you can see here, most of them are included in our project. I'm sorry for this wrong figure. This was this was a slide about the cystatin. It is a biomarker used already since several years, and it is a surrogate of renal function. So cystatin is less sensitive to skeletal muscle mass, and is a more reliable measurement of renal function. It was what I tried to show you, that unfortunately you cannot see it. It was just a trial showing that in patients with normal creatinine values, cystatin can help in stratifying the prognosis of these patients, both in renal failure and heart failure patients. Other potential biomarkers are soluble ST2, galectin-3, and GDF-15. These biomarkers are included in our project, as you know. Briefly, ST2L leads to inflammatory gene transcription, and it is inhibited by the soluble form of this biomarker. Galectin-3 binds beta-galactosidase and is produced by the lung and the liver, whereas ST2L is produced only by the lungs and is related to pulmonary congestion and inflammatory conditions of the lungs, and GDF15 is produced by the liver. All these biomarkers have been shown to be related to prognosis in patients with chronic heart failure. But given that they are inflammatory markers, they are informative more of the inflammatory, systemic inflammatory situation associated to heart failure, so, rather than congestion. Maybe, we don't know. We are here to understand properly this. Up to now, we know that, for instance, AMP and natriuretic peptide are very sensitive to congestion, whereas these markers are more sensitive probably for inflammations, but it has never been assessed in a comprehensive way like we will do in our project. There is a study that has been recently published that incorporated some of these biomarkers, basically ST2 together with NT-proBNP and troponin, that is a well-known marker in cardiology. So this study incorporated these three biomarkers together with the common clinical variables in the stratification of risk of patients with heart failure, and they saw that adding these variables improved the statistical prediction power of the model. BIOTOOL-CHF, as you know, is the biobank from whom we will derive the markers, and we will test the new biomarkers. And the published study showed that bioadrenomedulin, BNP, GDF15, and CA125 included were able to stratify the prognosis in patients with heart failure and were able to guide medical therapy. We will include other biomarkers in our project, as you know, that are elencated here, and probably other biomarkers that we will discover. These are some of the new biomarkers that we included in the project, and these are very important because are expression basically of congestion also. For instance, CD146 is expressed by congested vessels. Adrenomedulin maintains the barrier function of endothelium and can be metabolized by some therapies for heart failure. And CA125 is produced by cirrhosis in response to congestion. So again, these markers can be elevated also in other internistic congestions. For instance, we can find quite commonly this marker increased in lung cancer or in ovarian cancer, but in the setting of heart failure, they have to be tested. So to conclude, practically, to favor, actually, this study is very, very important BIOTOOL-CHF because assessing congestion can and guide the use of diuretics can help us in avoiding an excessive use of these drugs, thus aiming to spare the kidney in favor the guideline-directed medical therapy. And this is absolutely the crucial aim of our project. Of course, heart failure these are more personal consideration, is the kind of disease that every physician thinks to know and to be able to treat, but that in the reality can be treated more in detail only in specialized centers as by using sophisticated techniques like the biomarkers that we are going to test in our project. Several internistic conditions are at risk for heart failure, like liver cirrhosis, renal failure, and other conditions, but we don't know the real prevalence of heart failure behind the curtains, under the curtains in these populations. And this is something that our project could help us in discovering if we will be able to identify simple biomarkers that we can test also in other non-cardiological conditions. It's also tricky sometimes to differentiate this condition from other internistic problems. And finally, biomarkers can definitely help us in the management of this disease. Okay, thank you very much. I hope to don't have been too long.